Good.
Good morning. There's an echo, I think, on the, is there an echo? Morning. Are we? Is it sorted? Good morning, honorable members, everyone else, the department, our researchers, our content advisor, our legal services personnel from both sides of parliament and the state law advisors. Who have I missed out?
Can you check with the people on the platform if they can hear us?
I didn't hear you, the Honorable Munyai. I said you miss honorable members. Honorable members, yes. One must acknowledge the members properly. We need to just check who's on the. Can you hear us, honorable members, on the virtual platform? Maslengwa, I see you there. Can you hear me? Yes, thank you very much. So, honorable members,
Chair.
welcome.
Yes, Chair, we can hear you.
Thank you. So, honorable members, welcome to this meeting, which is a meeting of the Portfolio Committee on Health of the National Assembly on the 31st of August. Welcome also to Parliament for our first committee meeting at Parliament itself after 2 years. So you all look so happy to be back here, to be participating in this fashion. And thank you to all of those who came to attend physically. We're hoping that we would be able to move away from the hybrid meetings very soon and have most of our meetings be attended physically. Before we continue, I may need to make certain of attendance here today. I'm going to ask the honorable members, since this is now we're in our new place, to introduce themselves. Start with Honorable Siwela there, and then we come down the line.
Good morning, Chair. Good morning, colleagues. My name is Siwela Elvis, member of the Portfolio Committee on Health.
Good morning, Honorable Chair and honorable members and the representative of the department, researchers, and all supporting team. My name is Chilizi Mnyai. I'm a member of the Portfolio Committee. Thank you.
Good morning, Honorable Chair and honorable colleagues. My name is Xiaomei Howard from the Portfolio Committee Health. Thank you.
Good morning, colleagues and everybody present. My name is Naledi Chirwa, and I'm a member of this Portfolio Committee. Thank you.
Morning, Chairperson. Good morning, everybody. My name is Philip van Staden, also a member of this Portfolio Committee.
Good morning to all. It's lovely to be back in our normal offices and feel like we're functioning as a proper portfolio again. Welcome to all. I am Lindy Wilson from Limpopo, representing this portfolio.
Good morning, everybody. My name is Michelle Clark and a member of this portfolio, and it's really great to be back in an environment where we actually see each other and do the work that's expected of us. And I'm hoping soon we can have the same situation in Parliament. Thank you.
Thank you very much. The honorable members on the virtual platform.
Good morning, Chair. Good morning, honorable members. My name is Honorable Anna Gela. I'm the member of the Portfolio Committee of Health. Thank you very much, Chair.
Thank you, Honorable Gela.
Morning, Chair. My name is Honorable Jan Shakaba from the mighty organization African National Congress. I'm the member of this portfolio committee. Thank you, Chair.
Good morning, Chair, and good morning, colleagues. I'm Hasina Ismail. I'm a member of this portfolio committee. Apologies that I couldn't be there today. I have an urgent meeting after plenary today in my constituency. I will definitely be there at our next meeting.
Good morning, Chairperson. Good morning, everybody. I just have a complaint here. Who is unmuting us? Because it's a problem for us here. We are all members of Parliament and we are supposed to be part of this proceeding. So don't ever mute us. It's Dr. Tembekwayo, member of this Committee on Health. Thank you.
Who is next? Honorable Sengwa. Honorable Sengwa. I saw Honorable Sengwa earlier on the platform. But so we will take Honorable Sengwa as being present in the meeting. I will address your question after all the introductions and after we had I had read the, yes, Honorable Sengwa. Yes.
At last, somebody unmute me. I am Mahlengwa, Magdalena Tutuzile Hlengwa. I am a member of this Portfolio Health Committee. Thank you.
Thank you very much. I will now allow our PLO Joe Gatla to inform us who is present from the department.
Yes, good morning, Honorable Chair, Honorable members. On representing the Department of Health, we have the same team as last week. We are led by the Deputy Minister, who's logged in on the virtual platform. And here physically, we do have Dr. Nicholas Crisp, the DDG on NHI. We've got Dr. Akwena Tulare, a technical advisor on NHI. And then behind me, we have Mr. Moremi Nkosi and Ms. Kawekasi Kasamba, Deputy PLO. Thank you very much.
Thank you very much. You're all very welcome.
Oh, sorry, Chair, and Advocate Moabelo. And just to register also the minister's apology, minister is attending cabinet. Thank you very much.
Thank you very much. You're all welcome again, and also our Deputy Minister, who said he would be present this morning. So we thank him for attending. State Law Advisors.
Good morning, Chairperson, honorable members. I'm Aisha Johar from the State Law Advisors.
Good morning, Chair, honorable members. Theo Hercules from the State Law Advisor's Office. Thank you.
Thank you. Legal Services of Parliament.
Thank you, Chair. Good morning, members and colleagues. I am Suan Isaac from Parliament's Legal Services.
Thank you very much. And of course, we also have our staff present, our secretary, our researchers, and our content advisors. Honorable members, let me first officially say the purpose of our work this morning is to continue with the clause-by-clause deliberations of the Portfolio Committee on Health. We had ended last week at clause 33. We are hoping to move at a good speed again today. By now, we understand the process. I will read the bill, this clause of the bill, and we will then have deliberations on that clause. So before we do that, let me just read the rules of this meeting. And this is to remind you that this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of a committee of the National Assembly for official purposes only. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute their microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons of the bar at the bottom of their screens, which has an option that allows a member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order or interjections. Now, Honorable Themba Kwayo, you were not present in last week's meeting, Wednesday's meeting on the 24th of August. So I would understand that you do not, you're not aware of the decision that was taken that microphones should be muted. All microphones should be muted so that this very last point which I raised of unnecessary points of order or interjections are managed by myself. And I call myself on the Rule 80 of the Rules of the National Assembly upon which this decision had been taken. And I'm going to apply that rule today and for the meetings as we proceed. When honorable members want to raise a point of order or any other point, they must please raise their hands. Those physically present, I can see you from where I'm sitting. And those on the virtual system, we continuously look at that platform with assistance from the committee secretary, and then we recognize you in that way. So I hope that that gives you some clarity, Honorable Themba Kwayo. Honorable members, we will now—
Point of order, Chair.
Please raise your hand next time around.
That's not how Parliament works. I'm raising on Rule 92 of one of the rule book of Parliament. A member may raise a point of order at any time during the proceedings of the House, right? In terms of the procedure prescribed in Rule 66 by stating that he or she is raising on a point of order. By muting members and only unmuting them when you have noted them, you're taking away this right for members to be able to raise a point of order, as we do in the Parliament, because the rules of this book are applying here as much as they do in Parliament. By muting them and only noting them when you want to note them, you're actually contravening what these rules make room for.
Honorable Chirwa,
a point of order can be vocalized as we do in Parliament. I think it's very unfair for the chairperson to overrule and to overlook the rule book because of what is convenient for you as the chairperson of the House. The members on the virtual platform should have the liberty to unmute themselves and to raise a point of order, and then you can note them. At any point during the proceedings of this portfolio committee?
Well, I think you're quite wrong, your interpretation of the rule. I have said earlier that you're allowed to raise your hand. We're watching the platform, the virtual platform. And I see you as you're sitting there. Again, you have just done it wrongfully. Please raise your hand and I will allow any point of order as you wish to speak.
I will raise a point of order how I raise a point of order in the House in Parliament. If the speaker Ngakula can take my point of order when I say speaker point of order, surely the chairperson can do the same. And it's not an issue of interpretation. Whatever happens in that house applies here. You said this emblem in the beginning, that whatever rules apply in Parliament, they should apply here as well. So just have a fairness. Have a fairness. You can't mute members and only unmute them when it's convenient for you. Because I was on the virtual platform last week. You were not taking my point of orders. And as a member of Parliament, I'm entitled to a point of order. You can't take away the right of raising a point of order from members of Parliament.
Honorable Chair, I hear what you're saying. I have made a ruling and I'm basing it precisely upon the rules. And you were the reason of us now implementing this particular decision. Yes, that's why you're here. I'm very happy that you're here so that I can see you when you want to raise your hand or a point of order. Thank you. We will proceed. Dr. Tembakwayo, you've raised your hand on the platform.
Yes, I've got a problem here, Chairperson, because at the beginning, when I wrote a message here on our platform to say somebody must control the meeting, the host, I realized that some members who are on virtual platform were able to respond to your first question when you said, "Can you hear me?" The moment when we wanted to respond to you to say, "Yes, we can hear you," it's then when we realized that our things were muted. But on the same note, it's not all of us members who are on virtual who were muted. Honorable Gela was able to respond to you, which means there is a selective, there are those who don't have a problem with that, and there are those who are targeted to do that. If you want to apply the rules fairly, apply it to us, all of us that are on virtual. Let there be no selective giving people a chance to do that or not, please. And then leave this microphones to us to mute and unmute as we want to, because of the time of the response that we would like to render to you, because you do a selective closing and opening of microphones. Please be fair to that.
Honorable Tembakwayo, what you're saying is not correct. We unmuted them. Honorable Flengwa only waved her hands. That is how I knew that she actually heard. On the platform, if you had looked, you would have seen that she had waved her hands, and that was an acknowledgement that she could hear me. Secondly, we unmuted everyone as we were going along. Let's try it out, honorable members. There's no reason for not trying what we are doing. If it's going to assist this committee to move forward, let us please continue. Honorable Kaba.
Thanks, Chair. Chair, I raise my hand in support of what you have raised because you have confined yourself to Rule 80, except that, Chair, perhaps us on the visual platform, additionally, we can also raise comments on the side writing in case there's a problem that is privy of us to can raise more comments. But also, Chair, just to confirm that indeed, last week, we had to arrive at a point wherein we must control the meeting. As we are raising our hands, we'll do so as you direct, Chair, and we are ready. Thank you.
Honorable Gela.
Thank you very much, Chair. I'm covered by Honorable Kaba, Chair. Thank you. You can proceed with your meeting, Chair. Thanks.
Thank you, honorable members.
Chairperson, can the host unmute my mic indefinitely, please? Can my mic be unmuted indefinitely, please?
Where does it say member must raise their hand first?
It says members must
May raise a
hands
point of order
and
at
may
any
speak-
moment.
and may speak when they are recognized. to
Yes,
speak.
but you raise a point of order. It
It's
can
the
be
same
verbally
point.
as well.
Raise your hand and I'll
We want to
recognize
raise it verbally. We have a right to do so. We do so in parliament. Why can't you run this house like we are running in parliament? And if our mics here are muted, why should the members all on the virtual platform be muted indefinitely? There's no fairness in that. Look, now I just opened my mic and I spoke. What's going to happen? You're going to mute this mic, or you're going to call men to come chase me out of this meeting. Be fair. Just be fair. Unmute their mics and then run the meeting as you have done before.
Honorable Chira, please do not come and disrupt our meeting again. I'm going to do this meeting as I decided, having considered the rules. Please write where you need to write if you differ with what I am saying. We're going to do this today. I've made my decision. We're going to do it as we're doing. Thank you, honorable members. The title of this particular clause is National Health Information System. The fund must contribute to the development and maintenance of the National Health Information System as contemplated in Section 4 of Section 74 of the National Health Act through the information platform established in terms of Section 40. Subject to the provisions of the National Archives and Record Services of South Africa, 1996, Act number 43 of 1996, the Protection of Personal Information Act 2013, which is Act number 4 of 2013, and the Promotion of Access to Information Act. Data must be accurate and accessible to the department and the fund, or to any other stakeholder legally entitled to such information. Health workers, healthcare service providers, and persons in charge of health establishments must comply with the provisions in the National Health Act relating to access to health records and the protection of health records. Before I'm going to take hands, I'm going to take the hand of Honorable Themba Kwayo, who's raised a hand on the virtual platform first, before I was finished reading. Honorable Themba Kwayo.
No, I was still on the point of being unmuted. I raised it during the time when we were discussing that, to say we don't have to be given an opportunity to view our points, to say something about it only when our hands are raised. I need to do it any other time when I need to make a point of order. And that's that. With the questions, I'll follow later. Just identify whoever you identify, I will follow. Thanks.
Thank you very much. I'm going to accept hands. Honorable Munyai, Honorable Clark, Honorable Siwela, Honorable Ishmael, Honorable Tlengwa, Honorable Kaba. I just need to note this down now.
Honorable Chairperson, you have made a decision after deliberations. Rule 92, subsection 12A indicates that when you have made a decision, we have to move forward. If a member is not happy, the member knows what to do in terms of the rules. Thank you. And also Rule 142 clarifies that. Thank you. Because let me further clarify, Chair, because endless point of order may regard as a disruptive to a meeting, especially when you have taken a decision, Chair. You have to move forward and defend your decision.
Honorable Chirwa. Thank you very much, Honorable Munyai. So let me take the hands on those who want to deliberate on this clause. I had started with Honorable Munyai, but
I thought maybe you wanted
Yes.
us to deliberate on
All
the
right,
point of order.
thank
Can I
you.
please make my, okay, I'll come and make my contribution, Honorable Chair.
yes, so let me start with the hands again, because I must also note those hands. It was Clark. Yes. Yes. Ismail. Mhm. Mhm. And okay, so I'm going to start with the names. It was Clark first, Siwela, Kaba, Ismail, Hlengwa, Gela, Tembakwayo, Harvard, Munyai. No one else. I'm going to repeat. Clark, Siwela, Kaba, Ismail, Hlengwa, Gela, Tembakwayo, Harvard, Munyai. In that order. Wilson and Chirwa. So Wilson and Chirwa before Harvard and Munyai. Okay, so I'm going to repeat. It's Clark, Siwela, Kaba, Ismail, Hlengwa, Gela, Tembakwayo, Wilson, Chirwa, Harvard, and then Munyai. In that order. Thank you.
Thank you, Chairperson. In all the confusion, are we on number 34 now? Am I correct? Okay. Chairperson, if you look at section 74 of the National Health Act, it does say that there should be a coordinated implementation by provincial departments, district health councils, municipalities, and the private health sector of health information systems at a national, provincial, and local levels in order to create a comprehensive national health information system. The issue I have around that is it's all very well that's stipulated in the Act, but in the environment, it's not happening. So, you know, many hospitals do not have access to internet or phones or working computers. And what would the department put in place to make sure they change this environment before implementation of the bill? Thank you.
Thank you, Chairperson. Well, with regard to clauses 34, I rise to indicate that the 34.1, I rise to indicate that the African National Congress support this clause for the following reason. For the NHI to be successfully implemented in a sustainable manner, an information system that can generate valid and reliable information at the right time and in the correct format for planning and decision-making at all levels of management is required. For the NHI fund to carry out its functions effectively, it must be able to know what is happening administratively, financially, clinically, and productivity or performance-wise in real time and with easily accessible and usable information. Furthermore, the country needs to access readily available quality data and information for policy development, informed decision-making for health resources, planning and allocation, and monitoring and evaluating service delivery access. Without this, it won't be easy to assess the population's health needs and how best they can be addressed. One common interoperable platform for data management, planning, and decision-making was established during the management of the COVID-19 pandemic, see Section 40 of the NHI bill. Lastly, Chair, the patient or user must always be placed at the center of the information platform to support portable health records that will improve access and reduce waste when there is duplication of investigations, including laboratory tests and lack of transparency. Thank you, Chair.
Thank you, Honorable Kaba.
Thank you, Chair. Chair, I think I'm happy that you are directing us that we are confining ourselves to clause 34, not the entire. Must be enhanced to eliminate system risk, but more specifically to ensure that data is secure, that designated authorities can only access it, and that there are appropriate backup and storage systems. That's one check. Two, the Protection of Personal Information Act, POPIA, must be strictly adhered to, protect the patient privacy and to ensure that users are managed in a dignified manner without the risk of harassment from those that may gain access to this information. Three, Chair, that promoting of Access to Information Act, PIA, must be adhered to by ensuring that the provided information is depersonalized. This will ensure accountability and transparency without compromising and prejudicing confidentiality of users. Lastly, Chair, this information should be kept for 30 years in line with the National Archives and Record Services of South Africa. The ANC support this clause, Chair. Thank you, Chair. I submit.
Good morning, Chair, again. I just have a few pointers on this clause. I'm just a bit worried about this clause, as presently we have a problem with data on the system. Now, I've been approached by so many people, trying to get some sort of thing of information from hospitals or clinics, in order to apply for their children's birth certificates or even IDs for that matter. And they say the hospital says they have lost their information, or files that were moved from one hospital to another, have been lost, and now they can't assist with any records. And obviously this makes it almost impossible for a child to be registered. Now, Home Affairs as well don't have all the documented records as necessary. Now, I would like to know, considering we can all say that this is going to be implemented and taking place, and it's stipulated in the Health Act, and it's now stipulated in the NHI, bill. But how on earth is this going to work, considering the amount of recorded data already lost? And how long is it going to take for all the, present data to actually be collated and updated timelessly? That's one. Two is that, record keeping processes for continuity of care are essential. Now, again, currently there are numerous challenges with data collection, patient record keeping, and transfer of information between the different tiers of the health system. I don't know how long it's going to actually take for all this to be correlated, considering that we have so many issues on the system right now. The third point is that, healthcare workers, including therapists, have limited access to computers at the district or rural level. And therefore, it is actually, it's unclear. System developed should be an intelligent digital healthcare system that is actually compatible, with the various platforms in current use by practitioners. But again, I'm going to highlight the timeframes is essential, and it's very important to note that will this actually be done on time as what you anticipate this bill will be implemented by? Thank you, Chair.
Honorable Sengwa. Honorable Sengwa.
Sure. Chairperson,
Yes, thank you. We can hear you, Ms. Sengwa.
thank you. Greetings to all the members of the portfolio as well as the department. Clause number 34, National Health Information System. In this clause, Chairperson, one would request clarity regarding the timeline for the development and maintenance of such a system. And again, one could point out the state of the public maintenance, the state of the public healthcare services in South Africa, specifically in light of governance and management issue, the ability of the funds to develop and maintain such national health information system. Thank you, Chairperson.
Thank you, Honorable Gela.
Thank you very much, Chairperson. Chairperson, firstly, I want to align myself by supporting Honorable Suela and also Honorable Klaba on clause 34, their submission. But my submission, Chairperson, is based on clause 34.3. The African National Congress support this clause for the following reasons. Number one, Chair, there's a need to be consistency between the National Health Act and the National and also the National Health Insurance Act, and hence the healthcare workers in change of health establishment must ensure that they comply with the National Health Act by reporting of this by reporting depersonalized and aggregated data that will inform the National Health Information System. Secondly, Chair, this clause is in line with Section 15 of the National Health Act, state that I quote, one, a health worker or any healthcare provider that has access to the health records of a user may disclose such personal information to any other person, healthcare provider or a health establishment as is necessary for any legitimate purpose within the ordinary course and scope of his or her duties, where such access or disclosure is in the interest of the user. ANC therefore support this clause, Chairperson. Thank you very much.
Honorable Tembakwayo.
The EFF does not support clause 34. And please take note that the other substantial matters that will indicate the rejection of clause 4 will be intellectually presented by Honorable Chirwa and supported by myself on behalf of the economic freedom fighters. Pertaining to clause 34, the National Health Information System, accordingly, there are a lot of challenges as opposed to advantages that makes us not to agree with this clause. With specific reference to data collection, the file system, which is corrupt and where there is no backup and it's not even correctly captured. For example, some patients will go to the hospital or clinic to consult only to find that their files are lost. So with a lost file, what does it mean when we say the National Health Information System is correct? It's not correct, and it cannot be supported at this present format because there's a lot of fragmentation, the data that is not managed accordingly. My advice is let us first go back and create a proper national health system that is accessible, simply accessible to specifically to our rural and very deep rural people that also are part and parcel or would like to be part and parcel of the NHI. So as I said before, the EFF will not be able to can support this clause. Thank you, Chair.
Thank you, Honorable Chair. I rise indicated.
It's Honorable Wilson.
Oh, sorry.
Then Honorable Chirwa, then Honorable Abbott, then Honorable Munyai, and we have another hand, Honorable Van Staden. And then Honorable Clark, you spoke already, you want another opportunity. And then again, Honorable Clark.
Thank you, Chairperson. May I continue?
Yes, please.
Thank you, Chairperson. I have a lot of issues around this clause, and principally because we know where we stand at the moment as far as this is concerned. I mean, we have the Department of Limpopo spending 1 billion rand over 60 months to scan old documents. They haven't even started on the new ones. This is historical records of patients. Which already is problematic because I'm not sure what confidentiality clauses have been signed with that particular company who's scanning all of those records. We have a POPI Act that we have to adhere to, number one. I'm not even sure that that is covered. And in terms of the Health Act, confidentiality is key. So when you have an outsourced provider who's scanning millions of documents of people, they have an incredible amount of personal and confidential access, confidential information at their hands. And that for me is hugely problematic. Now, toilets, showers, cleaning rooms, what have you. Number one, there's no, I mean, those things are so accessible, it's frightening. There's absolutely no confidentiality maintained in those areas at all. Some of them have been there so long, the boxes have collapsed, the information is in disarray. There are patients' records lying everywhere for any person to come and see. So already all of those facilities are in breach of the confidentiality clause, which is section 14 of the Health Act. So in section 17 particularly of the National Health Act deals with the protection of health records. Now, given what we know is happening in Limpopo, given what we know, and we experience this because we do oversights on a regular basis of the current condition of medical records in this country, given what my honorable colleague said a short while ago, they don't have data, they don't have computers, they don't even have a telephone. They have no access to Wi-Fi. They have no access to anything relating to an internet. And I would say probably in the rural areas, 98% of those people in those facilities wouldn't even know how to turn on a computer, let alone operate one and connect it to the internet. I don't know how you will pull off clause 34, given the current state of affairs in this country. And we have often turned away acts and bills, number one, based on the cost, and number two, on the ability to actually make sure it can happen. And quite frankly, I do not see how you would make this happen. Thank you very much.
Thank you very much, Chairperson of the Portfolio Committee. I think, it's a contentious issue, this issue of the information systems, because as the previous speakers have said, we know the current situation in the country, right? There isn't an information system that is working, that is thorough, that has been developed by the ANC government for the past 30 years. And yet the NHI is proposing to us that in the coming 6 years, there will be a working information system. And this is not just for health, this is across the board, across all departments. Whether you go to the traffic department, whether you go to the police, there isn't a working information system that has been developed by the ANC government in the past 30 years, right? And in the instance where there is 10% of the effort that is put into developing an information system, it's riddled by fraud, it's riddled by corruption, it's riddled by incorrect information, it's riddled, people are able to buy identities, which is also a contentious issue in the country as is. And this particular clause does not make room of deciphering to us or the nation what will be the modus operandi of ensuring that, firstly, that this particular thing happens, despite the fact that we know it won't happen in the coming 5 years if they failed for the past 30 years. And secondly, another issue I want to raise in relation to this, and just general, and I'll keep on raising this issue because as we go about the day of the business of the day, you'll realize that it's actually a serious issue if you give it a proper thought, right? And I raised it even in the past meeting as well. I want to know what then becomes the default system of those who are not registering with the NHI, be it the users, be it the service providers, right? Because there is no clear indication of what then the health system looks like for those who are not registered, as there is the liberty that's also given, even with the ushering of the NHI. Number three, there is no clear indication if this will be an internalized system or if it will be outsourced. So this particular clause must be very clear on what we are working with. Are we working with another tender or working with another failure of building state capacity? And we also want to know how will the transfer of information of the current database take place, noting the current situation of information systems in the health department across the country, worse in remote areas, worse in township areas, worse in informal settlements, for a lack of a better word, right? And lastly, I want to know if capacity will be internally increased, because it's not also deliberated upon, it's just that it will be developed and maintained. But will this be done internally to increase state capacity or not? Noting as well the current backlog and issues with generally building state capacity under the ANC government. It is not doable, this thing. We're just raising our hopes for something that's not going to happen, especially through the ANC government, whether you are doing it by outsourcing or whether you're doing it by internally increasing state capacity. It's not going to happen. And it's a high aspiration that the ANC government will not be able to reach. But more than anything, I want to know what then becomes the default system of those who are not registered with the NHI, because this clause doesn't make room to cater for that particular question, whether as a user or whether as a service provider. Thank you, Chairperson.
Thank you, Honorable Howard.
Thank you, Honorable Chair. I just raised to indicate to support inputs made by Honorable Siwela, Honorable Gaba, and Honorable Gela. ANC support the entire clause 34. Thank you.
Honorable Chair, thank you very much for the opportunity. Firstly, I must say that there's no clinic in the Republic of South Africa, no hospital that doesn't have computer. Wait. Can you allow me, Honorable Chair?
Please continue, Honorable
Yeah.
Munya, you are protected.
Yeah, thank you very much for protecting me. That is a fact, but maybe let's help that computer in these days is not only, in addition to those computers that I've mentioned, the big telcos, I must say, the Vodacom have, as of 2020, 44.3 million subscribers. MTN have 28.6 million subscribers. Telecom, 9.3. And then, no, 9.3 Cell C, Telecom it's 14.9 million. In case you don't know, phone can work as computer systems. This is a ABC of information systems. Let me come to the information system, Honorable Chair. Information system is an enabler and a backbone of the healthcare service delivery. For example, Honorable Chair, in UK, NHLS is being delivery of the service of the NHLS is being done through the company called Babylon ICT to support the health information system. In that context, Honorable Chair, maybe just to further conclude, Chair.
Honorable Munya, here's a hand raised by Honorable Chirwa for now.
Thank you very much, Chairperson. I just want to correct the factual statement that Honorable Munyai made, that there's no clinic without a computer. Here in Cape Town, there's a clinic called Guyasa. It doesn't have computers. And in Pretoria, there's a clinic called Kazankulu. It doesn't also have computers. So he must just correct that, because he said it's a fact. And we don't want to be lying to the public that there's clinics that all clinics in the country have computers. From the top of my head, I can give you 2 that don't have computers. And this is in cosmopolitan areas, Pretoria and in Cape Town. Thank you, Chair.
Thank you. Honorable Munya, please continue.
I'm not in a contestation. I want to continue with the facts. Number 1, may be protected and not really be Honorable Chairperson. This is unparliamentary.
Yes, Honorable.
Can Honorable Chiro withdraw?
Honorable Chirwa, can I be allowed to make my own ruling? I'm ruling about what you said, that he is lying. That is unparliamentary, as you do know. Can we first?
I did not say it like that, Chairperson. Be honest.
I heard you from here. Your microphone was not on, but I heard you, and the other members also heard it.
Rule on that, and there's a member of parliament who is sending mistruths to the public that it's a fact that there's clinics that all clinics have computers. I gave you 2 clinics from the top of my head.
Where's that thing?
It's incorrect what you said, and we can't be making mistruths in a portfolio committee.
Now that's now Honorable Chair. Honorable Chair, give me an opportunity to speak. I read the rules again. When the chairperson speaks, you need to show the respect to the chairperson. When the chairperson speaks, you need to refrain from speaking. All of you honorable members. Until you are given an opportunity to speak again, when that chairperson has completed what he or she wanted to say. Now, 2 things here. You are making a statement that what Honorable Munya is saying is not correct. We heard you. But he does not have to withdraw, because that is his contention, that every single clinic has a computer, rightly or wrongfully so. But you need to also apologize for saying he is lying. I heard you say it. Honorable Chirwa, please, let's try to go forward very amicably.
I must apologize to Munyai.
For saying he is lying.
That is
the
the
word
truth.
lying. It's not the same as saying it's untruthful.
He is
You
not
said
telling
he
the
is
truth. He's
lying
misleading the
under your
country.
breath.
He's misleading the country in parliament, in a portfolio committee. Is that
Honorable
better?
Chirwa, let us not go down the wrong road.
May I please proceed?
Please proceed,
I don't get
Honorable
any
Please proceed.
benefit from any apology or withdrawal. Thank you. The people of South Africa know that the ANC government has developed the COVID-19 data systems, and it is very useful for the whole country and never leaked. Vaccination in EVDS, which is under full control of the National Department of Health, with 100% compliance of security prescripts and data governance aligned to POPIA. Not true that the ANC has not created a data system that is functional. And as I said, Honorable Chair, that the information system, it's a backbone of the delivery of the services. In that context, I hear rising to support the contribution of Honorable Siwela and Honorable Gela, Honorable Taba, and also I stand with what Honorable Harvard would have supported. And again, Honorable Chair, will send the formal written submission of the ANC, honorable members made by the ANC. We didn't do last time because we needed to have substantial number of submissions. So we'll send it after the end of this session. Thank you.
Thank you, Honorable Van Staden.
Thank you, Chairperson. Now, I understand that this clause said is going to be subject to the provisions of this law and that law and this law again. But I try to understand how the system is going to work. I understand that the population register will be integrated into this system, if I understand correctly. But the problem I'm having is, like the other members have said, if you go to many state hospitals and clinics, and the Auditor General also came and reported into this committee before lockdown. In fact, it was in the same committee room, I think. On the hundreds of files of data who's piling up into the wards in some of the state hospitals. So that is problematic. So I try to understand how the system is going to work, how that data is going to be transferred to electronic system, how much is going to cost the taxpayer to do all the data. If you remember, if I can quickly touch on the Department of Transport, when the e-NATA system was introduced as law in the middle 2000s, 2007 to 2008, it cost the country billions and billions of rands to transfer from the old MVR system to the e-NATA system. And this is not going to be different at all. So the problem first we're having is with the data files piling up into the hospital wards. The other problem is patient files is getting lost at hospitals. So my question is, a patient file is getting lost and it's not yet transferred on the data system, then the patient must get a new file. So where is all that old information going? So how is that going to be integrated into this new system? I understand what Member Munyai is saying about the Vodacoms and Telcoms and all that other service providers. The fact of the matter is, it must be, as I understand it, one integrated system like e-NATA, which one hospital is speaking to another hospital on a computer system, if you understand what I mean. So if you go, for instance, to Steve Biko, you're registered as a patient there, all your information is up there, and you're coming to Grote Schuur in Cape Town, then all your information must be also there. It's like the motor vehicle license system. So that is my big question is, how will that data, which is now not on the system, how long will it take before it's onto integrated system? How long before integrated system is launched, and what is the cost going to be on the taxpayer's pocket to launch such a system? And remember, Minaya is not correct. There is many clinics and hospitals in this country which I have saw with my own eyes, but don't have that compatible systems to work with, and don't even have data capturers who can do that work. And that's also a problem. So there must be someone appointed, a data capture appointed, at least at each and every clinic and hospital in this country, which belongs to the state, to capture that data which is not captured yet. And that's going to take a huge task and a long time to do that. That's just my input. Thank you, Chairperson.
Thank you very much. I have another few members who want to have a second round. I'm going to raise them in the order that I saw them raised on the system. Honorables Clark, Wilson, Gela, Kaba, Ismail.
Thank you, Chairperson. I'm broadly covered by Member van Staden. I mean, this is not a Mickey Mouse setup that we have to do here. You know, if you just look at a pharmacy like Dis-Chem, you can go to any Dis-Chem around the country. They have an integrated system that can find you and dispense for you. I mean, your service providers are people like Vodacom, MTN, etc. But your software package for this kind of integrated system, for example, SAP, is what you're going to probably need in order to integrate all your hospitals. So I'm also requesting that we have a presentation by the ICT department to show us exactly how they intend doing this, because it's a huge exercise this in order to make it functionable. And I mean, I must tell you, I've also done lots of oversights. I mean, a hospital like Pelanomi, which is a huge hospital in Bloemfontein, don't have computers. So, these are facts, and we are here to actually rectify the problems and to ensure that every person in this country actually has universal health care going forward. And, it doesn't help us as a committee fighting against each other. We must accept brass facts and concentrate on those facts and make sure that those facts are corrected. Thank you.
Thank you, Chairperson. I think I'm principally covered by the Honourable van Staden and the Honourable Clark. And with all due respect to my colleague, the Honourable Munyai, be careful when you start quoting MTN and Vodacom figures, and I'll give you a reason why. In my household alone, in an urban Polokwane suburb, we've got 9 Vodacom contracts, 9, between fiber, my husband, my son, myself, my grandchildren, and. So when you start taking the figures that you are quoting, sir, and seeing where those service providers are actually established and how many they are in one household, you're going to come unstuck with your figures by saying there's 14 million people on it. So I'm just saying be cautious, because if there's 9 in my household, there might be 6 in the house next to me, there might be 5 in the house next to me. So we're talking about subscribers, 7 or 8 Vodacom subscribers in one house. And that, besides that being the point, and you will know this if you do actual oversight and go out into the rural areas, that the people in the rural areas have very, very old cell phones. We are very fortunate. We have smartphones. The bulk of the people I meet in the rural areas do not have smartphones. And no, they cannot be used as a computer. And the moment you start using a cell phone as a computer, you are going to instantly breach the confidentiality clauses that we have just been discussing, because the easiest thing in the world to hack is a cell phone if you're not cautious. So I want to just say that let's us be cautious when we start bandying figures around, because when you start taking a breakdown of those figures and where they actually are and how they are decimated, you're going to run into a problem. Thank you, Chair.
Honourable Gela.
Thank Chairperson. I was waiting for the host to unmute me, Chairperson. Chair, I want to start by saying to honorable members that we must remember that we are here to serve the people of South Africa. And the African National Congress has done a lot to change the health system as it was before. We can see now a difference. There's a huge difference that is happening in our health system. Coming to the issue, I want to say Honorable Munyai is correct. The department has reported to this portfolio committee that they have distributed computers to all PHC facilities, except in 42 facilities where there are electricity challenges. So where there's no computers is because of the electricity challenges in those areas. But I think, Honorable Munyai, you are correct, and I fully support you on your input. But also coming to the issue, Chair, that I also want to contribute on based on the questions that were raised by other honorable members. That the health patient registration system, it will become the source of the NHI users, already has more than 60 million records and more than 35 million records having IDs. None of that has leaked. It has been installed in 3,150 a public health facility. This is built into the system solution, strictly access control. Data is stored in a secured data center belonging to the Department of Health. I hope, honorable members, you get my point. Thank you very much, Chairperson.
Thank you, Honorable Kaba.
Yeah, thank you, Chair. I think what I wish to also add upon comments raised, Chair, is that the department is continuously verifying all processes against POPIA, and they have access to a cyber security specialist, which is quite key for us to understand. The other thing, Chair, is that like Honorable Gela, I concur with him, I support him, to also mention that the system is already developed, and for EVDS and Department of Health is doing bulk verification with Home Affairs Population Register. This is not a rocket science. It's a fact happening. Once more, Chair, in support of you running our meetings, maybe it's best that we refer to members as honorable, like earlier Honorable Shirwa mentioned Munyai. I think we call each other honorable here. We must give clarity, Chair, that for us to contribute here, we are not agitated, excited, or in expression of moves. Our responsibility is to be factual. We provide clarity. We respect people of South Africa, and we allow them to listen respectfully to Parliament. So it's very clear that the manner in which we conduct ourselves has to possess a respect wherein the next listener can listen to you. Also, Chair, to Honorable Staden, maybe asking as to how are the system going to work. Chair, I think for us here as members of Parliament, we are making law. Matters of implementation are matters of people we employ, the HOD and the other systems and the administration and so on. But for us here, we are coming to make law. So matters of implementation, if we have passed this law, like NHI, we are going to pass, for the implementers, they have to focus in that. Thank you, Chair.
Thank you, Chair. I just have a few
Honourable-
issues that I want to.
All right, later. All right. Continue, Honourable Ismail.
Thank you, Chair. I just have a few matters that I want to raise. I think firstly, I just want to put on the record that, I think as honorable members on this portfolio committee, if we can stop, starting to actually address or respond to fellow members, I think 90% of these glitches can be avoided. I mean, we put our inputs on the table, expecting the legal advisors to come back to us at the end or the department to respond on how there's going to be amendments or taking into consensus of our inputs when getting, the final discussions on the table. So I want to also specify that, when it comes to certain issues raised in response to our inputs, I'm partly covered by Honorable Wilson when it comes to the issues of Vodacom, Telkom, etc. And on the issue of computers and those things, I think it's in my first statements, I actually specified we need more specifics on, how it's basically unclear in this bill, which it's supposed to be, there's supposed to be clarity on specifications on how the system will be implemented, considering that, there is not sufficient infrastructure, human and financial resources to enable this national health information system to actually work. So that encompasses everything, whether it comes to infrastructure, that is electricity or computers. But I wanted to also point out, when you're looking at the EVDS system, it's not, it wasn't necessarily functioning optimally without any glitches as well. And when we are giving our inputs here, we are trying to say any system that is actually being implemented right now is not 100% functioning properly. I mean, I myself had to, escalate a few issues to the department with regard to EVDS when, citizens of this country actually highlighted that I'm having issues here and it's not picking up on the other side. So there's no actual system that's functioning properly. And therefore, I'm going to come to the other pointers to be able to say that the NHI bill does not provide clear guidance on the new biometric system required. All the coverage required of the IT system that will track registration, provide electronic record keeping, and manage transferable records. This is important for it to be stated in the bill. Another point is that, there's a lack again of specifications regarding the extent of development of this health information system, and a lack of recognition that the current constraints to the collection of data are as a result of staffing shortages, particularly at primary healthcare levels. It's important for all these matters to be specified in this bill. The challenges must be specified, and how these challenges are going to be overcome must also be specified with timeframes. Another matter is that the National Health Information System, envisaged in this clause 34, section 3, it must actually be strengthened again to ensure that, in addition, it must specify in addition to the provisions of the National Health Act. And it must also specify that it must also comply with the requirements of this act, so that we know everything legally. We're looking at what is being done in this bill that is actually legally compliant and regulatory compliant, and it's all well and good to say that there are regulations somewhere in government and in the department, but reality is that it needs to be specified in this bill. And I'm also going to say again, the Office of Health Standards Compliance and the AG has come to our very committee some time back stating, and they showed us pictures to show boxes and boxes. Never mind we doing oversights, which we are obviously clarifying from there. But I mean, we've seen it, there's recordings, the PNG recordings of all these boxes that are lying somewhere, with all these records. And obviously, if you're looking at those boxes, they're damaged. There was water flowing everywhere. So obviously we don't have all those records that are necessary right now. And what we are asking is that under this particular clause, all the specification of challenges and how these challenges are going to be overcome. And also, I think one of my colleagues stated, we need to know how this information system is actually going to be working. Because we already say, it's all well and good to say, this is in place and that is in place and that is in place. But the implementation of is not being done properly. Thank you, Chair.
Thank you. Honorable members, there are quite a number of hands raised again. I'm now considering how we must do this because some are now raising their hands for the third time. And yeah, I'm talking about Honorable Clark, for example. So I think we're going to allow it, but let's try not to, for us not to get to the point where we have 3-4 times honorable members raising their hands in the same discussion about the same clause. That's not yet you, Honorable Clark. I'm just raising this point, but I'm going to allow it now. So the names, those who have raised their hands are the following in the following order. It's Sewela, Van Staden, Clark, Tembakwayo. In that order, I'm going to repeat Sewela, Honorable Sewela, Van Staden, Clark, Tembakwayo. Thank you.
Thank you, Chairperson. Once again, I must agree with you that we should be able to move forward. We are here to discuss the clauses. However, people are not forbidden for responding to certain issues that are being raised. What I would like to indicate, Chairperson, is that obviously I am from a rural community. Some of these things that are being said about rural people may not necessarily be correct. We should not think that they are not part of South Africa. They are part of South Africa, and most of these things that the department it's saying is doing, it's happening in these communities that we are coming from. So I just want us to be very careful when we talk about rural people as if they are from somewhere, they're not part of the whole world. Thank you, Chair.
Thank you, Chairperson. No, we are, yes, we are lawmakers, and that's our job. That's what we do. But we cannot put a law onto the books when we don't discuss the practicality side of it, how it's going to roll out in communities. And that's the problem with most of our work in South Africa, I think at the moment is, but it looks fine on paper, but when it comes to the practical side in the communities, that's where the problem started. So you must discuss the practical side on how it's going to roll out while you're discussing a bill. So you must sort out all the problems before the bills go to the table and it's going into law. My other problem with the data is what happens when the data will be breached. We know some parts of, I think there's a section in the POPI Act which say that if data is breached at a facility, the person in charge of that facility or that facility will be liable to fine, I think it's up to 4 or 10 million rand. So that is my other question. What will happen if data get breached at the facility? And that is stuff we need to sort out. Thank you, Chairperson.
Thank you, Chairperson. I apologize. There was just something that I forgot to add in terms of the costing. And like Member Van Staden said, you would have to have really good firewalls in place, the way the banks do, in order to protect your system. And secondly, you also, in terms of your cost factor, you'd also have to tell us whatever system you're going to be using, what the license fee of that system would be annually. Because we all know, like Microsoft, for instance, you pay millions of rand a year to use that kind of software. So whatever system you're going to be using, if we could have the cost factor of the license fee as well. Thank you.
Honorable Tembakwayo, you'll be the last.
I'm not given permission here. Okay. Chairperson, thank you very much. I just want to say, you know what, the NHI bill is under the Minister of Health here. And here we are busy deliberating clause by clause. We are not reporting to the ANC honorable members here. So we don't need them to come and answer to the queries and the questions that we have. They must get us clear here. So we don't expect them to respond on our questions, nor our own way of seeing these clauses. And I did say it the other time to say, let them stop it, to keep on reacting to our statements and so on. We're not talking to them. That's why we ask that when it's possible, when can the minister appear before us and answer to a lot of questions that we are asking here? For them to say we are supposed to do this, the information, we don't need their reactions here. We are responsible, capable, intelligent, honorable members of parliament. We are saying our own things from our own political opinions. Thank you.
Thank you, honorable members. Thank you for that input from all of you. Just in my response, I have now refrained from saying anything. I've allowed all of you many opportunities to speak. At least that is one accusation you cannot make against me. So as far as inputs given, I think every member has an opportunity to provide input or clarification if that member thinks that a point had been raised that he or she wants to raise clarification on. And I'm going to be doing exactly the same, because this point of biometric identification is a point that I had raised much earlier in the discussion when we started on the clause by clause deliberations. And I would think that it will be responded to, but I would also think that the department would have progressed on it to now, and I'm certain that when they do come, they'd be able to give a clarification on where they are with this process of biometric identification. And the last one, Honorable Wilson, I'm trying to understand your point of subscribers in one house. Isn't that exactly the point, that all of those subscribers are adults within that house, preferably, they probably are, and that each one in his or her own right then is counted as a subscriber to a mobile network or a service provider. So it is not incorrect what Honorable Munyai was saying with regards to, yes, I'll give you an opportunity, with regards to the subscribers, number of subscribers of Vodacom and MTN, etc. In any case, one should be over the age, I think, of 18 in order for one to be recorded and to be able to have such a device or access to such a device and to the network itself. I'm going to give you raised your hand. I'm going to let you speak, and then I'm going to complete what I wanted to say.
Chair, no, I agree with you 100%. Subscribers are subscribers. What I was trying to say is that in a urban, wealthier area such as mine, you have several subscribers in one household. If you take the amount of subscribers that MTN has relatively, okay, so they've got 17 million or 40 million or whatever it is, and you put those into relative perspective, okay, how many of those are possibly in one household? How many of those are in the wealthier, more urban populated areas, and how many of those are rural? And I think if you do that kind of exercise, you'll find a very different picture to what the Honorable Munyai is actually trying to create. Thank you, Chair.
Thank you very much. I understand. And then finally, as we're going to rise for tea, honorable members, it is just for me to say that I support what had been said by the honorable members, Siwela Kabagela, on the clauses 34, 1, 2, and 3. And we are going to rise for tea now. It is 5 minutes past 11. Actually, 9 minutes, 10 minutes past 11. So we will be back at 20 minutes to 12. Thank you very much. Only one vacancy that side, not honorable members. So let us continue with our work. We are now at clause 35. Purchasing of healthcare services. The fund must actively and strategically purchase healthcare services on behalf of users in accordance with need. The fund must transfer funds directly to accredited and contracted central, provincial, regional, specialized, and district hospitals based on a global budget or diagnosis-related groups. Funds for primary healthcare services must be transferred to contracting units for primary healthcare at the sub-district level as outlined in section 37. Emergency medical services provided by accredited and contracted public and private healthcare service providers must be reimbursed on a capped case-based fee basis with adjustments made for case severity where necessary. Public ambulance services must be reimbursed through the provincial equitable allocation. So I will take hands now, honorable members. Thank you. I'll have the secretary read those to me. Ismail. Munyai. Clark. Van Staden. Siwela. Kaba. Tembakwayo. Dr. Harvard. Dr. Tembakwayo, Dr. Harvard. Chirwa. Hlengwa. Wilson. I'm going to repeat, honorable members, please look to see where you are in this order. Ismail, Munyai, Clark, Van Staden, Siwela, Kaba, Tembakwayo, Harvard, Chirwa, Hlengwa, Wilson. In that order, honorable members. I think try and say everything that you want to say. If necessary, we might go a second round, but definitely not a third one. But if it's possible, just once. Let's try and do this once only. Thank you. In that order.
Thank you, Chair. I just have a few pointers. Clause 35(1) states that the NHI must purchase healthcare services, in apostrophe is now, in accordance with need. Now, I'm just worried that this phrase gives rise to, great concern, as it could lead to non-stop litigation to actually determine what the need is and not according to the benefit it actually covers. That's a bit of a worry for me. There should be specifications. Also on 35(1), we should actually include in alignment with the PFMA in order to avoid issues and to ensure that we actually prescribing to the PFMA, or rather that the bill is prescribing to the PFMA. The third point, clause 35, section 2, does not specify for the purchase of services for example, from physical or for physical or substance abuse facilities, mental health facilities, maybe specialists in private practice, or even healthcare professionals for that matter, not working in primary healthcare. It's very vague. That's what I'm trying to say. We need to be more specific, and all these need to be specified, in my opinion. My next point is clause 35, 2 and 3 speaks to transferring of funds, but this is confusing me because the NHI bill speaks of a centralized system. So clause 35, section 2 and 3, basically, I feel contradicts what it actually states in other sections of the bill. Thank you, Chair.
Honorable Chair, if you may allow me, please.
Yes, please.
Thank you very much indeed. The African National Congress concretely support clause 35(1) based on the following reason, Honorable Chair. This clause enables the fund to fulfill its mandate as a strategic purchaser to meet the population health needs. Strategic purchasing is the active and evidence-based engagement in defining the service mix and the volume, and selecting the provider mix in order to maximize societal objective. It requires information on the range of issues such as the prioritization and cost effectiveness, staff and facilities, price, quality, and projection on available resources. It is aimed at improving the performance of the health systems and make it progress towards universal health coverage. It is undertaken by an active purchaser that pools funds on behalf of the population and purchases health services from the accredited and contracted providers, including emergency medical services. In consultation with the minister, the fund must determine its own pricing and reimbursement mechanism. Furthermore, the ANC support this clause on a strategic purchasing because, as clearly stated in the white paper on NHI, which refers to open quote, active purchasing by a single strategic purchaser using explicit contract that set prices, gatekeeping at the primary healthcare level, and provider payment reform that moves away from a fee-for-service environment to alternate strategies for reimbursement, close quote. This aims to improve the efficiency of the system to increase the value for money spent. Currently, the money in the both public and private sector is not spent equitably. I'm sure, Honorable Chairperson, you would understand the context of the two-tier system. Thank you very much indeed for the opportunity.
Thank you, Chairperson. In terms of one, what will the guidelines be for purchasing such services? How will the need be determined in real time? If all functions are to be centralized, will we not see massive delays in urgent medical treatments pending the red tape of purchasing healthcare services? More explanation needs to be given on how this will be done. Number two, what oversight will be done on such large amounts of money being transferred? Based on the global budget, does this infer that some services may not be either purchased due to the budget constraints or the healthcare providers will not be paid on time? And there should be some kind of consequence management process put in place in terms of the oversight of the funding. Number three, what oversight will there be to ensure that tenders, invoice fraud will occur or that amounts paid over will be used for actual healthcare services to be purchased? And number four, how is the capped case-based fee calculated? Have private sectors agreed to the cap-based fee? Thank you.
Sorry, thank you, Chair. I was partly covered by Member Clark, but my concern is when I read clause 2, it said the fund must transfer fund directly to based on a global budget. My worrying is, and we saw, and that's what we've been spoken about, the past 2 weeks while we're sitting in this committee is what will happen when this global budget gets looted by corrupt officials or corrupt politicians, and then the whole health system in this country will stand still. That's my worry. What will happen when this fund gets looted by corruption? Is there precautions in place to curb that at the end of the day, so that healthcare don't stand still at the end of the day? And on the cap case base on section 4, I also want more clarity on that. How is that going to work efficiently at the end of the day? Thank you, Chair.
Thank you, Chairperson. Firstly and foremost, I wish to support the comments made by Honorable Munyai on clause 35.1. Chair, with regards to clause 35.3, the ANC supports this clause with minor amendments for the following reasons. This clause stipulates that contracting units for PHC be established to manage primary healthcare services, such as prevention, promotion, curative, rehabilitative, ambulatory, mental health care, oral health, home-based care, and community care in a demarcated geographical area. They comprise a district hospital, clinics or community health centers, WBOTs, and private providers organized in horizontal networks within a specified geographical sub-district area. The ANC chair is of the view that the primary health care level, the contracting units for PHCs should not be established as a fund holders, but as a service planning units for the fund at a designated sub-district level. Therefore, Chair, the ANC recommends that the subclause must be amended to read as follows. Funds for primary healthcare services must be transferred to accredited and contracted primarily healthcare providers coordinated through the contracting units for PHCs at the sub-district level as outlined in section 37. The CUPs will assist the fund to identify healthcare services needs in terms of demographic and epidemiological profile of a particular sub-district, identify accredited public and private healthcare service providers at a primary care establishment. And they will also manage contracts entered into with accredited healthcare service providers, health establishment and suppliers in the relevant sub-district in the prescribed manner and subject to the prescribed conditions, and facilitate the integration of public and private healthcare services within the sub-district. They will be beneficial in the management of NHI service provision. The main mechanism that will be used to pay PHC's contracted providers will be a risk-adjusted capitation system with an element of performance-based payment. Capitation-based provider reimbursement systems are best suited for PHC services and will take into account the re-engineered PHC approach. A key issue will be to determine the capitation rate, that is the average cost of providing the clinic and community-based service per person, and similarly for CHC services, and later on appropriately adjusted according to age, sex categories. So I submit, Chair. Thank you.
Honorable Kaba.
Thanks, Chair. Chair, I rise in support of what Honorable Nyai and Honorable Suela had submitted on clause 35. Further, Chair, to indicate that the ANC support this clause with minor amendments for the following reasons. that clause 4, which relates to reimbursement of accredited emergency public and private providers and their reimbursement using a capped base fee with adjustment made for the case severity when necessary. This helps in cost containment while improving service provided. To manage and contain costs, payments for facility-based emergency medical services, EMS, will largely be through a capped base fee with some adjustment made for case severity when necessary. Payments for contracted mobile EMS will be through a capped case-based reimbursement strategy. And then, Chair, also the following amendment is like clause 4. I support that 4A be divided into subsection 1 and subsection 2 with the following definitions being included. That 4A subsection 1 reads that on the facility-based emergency, medical services provided, it should be like medical services provided by accredited and contracted public and private healthcare service providers must be reimbursed on capped case basis fee with adjustment made for case severity when necessary. 4A subsection 2, Roman figure 2, it be mobile emergency medical services provided by accredited and contracted private health. That should be care service provided must be reimbursed on capped fee basis with adjustment made for case severity when necessary. So I'm doing that subsection 4A have Roman figure 1 that speaks on the facility-based emergency, and 4A have Roman figure 2 that speaks on the mobile emergency medical services provided by accredited and contracted private healthcare. For other questions, Chair, as ANC participating in this portfolio committee, we will clarify answers in case members still have questions. Thanks, Chair.
Honorable Tembakwayo.
Thank you, Chairperson. The EFF does not support this clause, and the honorable member, Honorable Chirwa of the Economic Freedom Fighters, will also give us other intellectual matters to support our rejection of the clause, starting by saying the purchasing of healthcare information brings us back to the PPE saga that was characterized by the inflated prices that benefited those that were directly associated to the health department, as it has been the case and will forever continue to be the case even with NHI. So how can this be prevented to continue? The purchasing, like it was said to say, it should be done according to the need, not like it was the case with the COVID-19 vaccinations, where the millions of expired vaccines were purchased and no accountability was done by those that were in control. We must always remember that need is a broad word with specific reference to health, can include the minimum amount of resources required to exhaust an individual's or a specific population's capacity to benefit from an intervention. There is a need to redefine needs per health and quality of life outcomes. If the goal of the care is optimal health, the key marker of the success ought to be to ascertain individual patients' health care needs and tailor the services accordingly. As such, wide variety in the description of needs directly affects the policies and services intended to meet the population healthcare needs. Thus, the needs specification has to be deliberated on. We cannot just simply accept the inclusion of the word in that clause, simple as it is, but we need to deliberate further onto certain characteristics and disciplines that are included within the term needs. As a result, we, as the representative of the mighty economic freedom fighters, do not support this clause. Thank you.
Honorable Chair, I just rise to support inputs clause 35.1 made by Honorable Moyai, 35.3 made by Honorable Siwela, and 35.5.4 made by Honorable Kaba. For clause 35.4b, ANC supports the clause for the following reasons. The clause stipulates the public ambulance services must be reimbursed through the provincial equitable allocation. Furthermore, payments for mobile public sector EMS ambulance will be through the provincial equitable allocation. This is because ambulance service in the public sector are a provincial competence as contained in Schedule 5 of the Constitution. This is my submission. Thank you, Chair.
Honorable Chirwa.
Sorry, thank you very much, Chairperson. I'd like to agree with the sentiments that have been shared by Dr. Susan Tembagwayo, Honorable Dr. Susan Tembagwayo. And furthermore, I'm reiterating a point that I said in point 34, right? In regards to what then becomes the regulation method of external systems or for patients or persons who are utilizing health facilities who are not registered with the fund, or facilities that are not service providers of the fund, right? And implication of failure of registration of patients could possibly see an exclusion from medical intervention because of this particular clause. I think this should be deliberated upon, and we should get proper feedback on how this will be avoided. And number 3, we'd also like to know who purchases the medical devices, medicines, tools on behalf of persons who are not registered with the bill. And if external facilities and institutions can still provide or cater for these particular aspects if they are not service providers of the bill. And then what happens in that space? Because in as much as we are saying we are breaking down the 2-tier system, this is a sentiment I shared even before. If persons are not registered with the NHI, if health facilities are not service providers of the NHI, we're still left with the existence of a 2-tier system. And even in that 1-tier system, in inverted commas, there still exists a private sector and a public sector, just the government outsources from the private sector and then pays them through the NHI. And in the instance that the fund runs out of funds, as will be the case, as you see in this particular clause, there's even a possibility for that particular thing, and it's been a contested issue, the issue of cost, right? What then becomes the modus operandi, and what are the financial projections of such an instance? So if this particular clause makes room for that being a possibility, can we go all the way so we also see what is the exact probability of this particular thing happening? And this clause releases the government from the financial burden, in the sense that which is unacceptable, firstly, and will be problematic in future when the fund can no longer cater for health needs. And this clause will then be quoted in protection of this incapacity, because it makes room for that kind of incapacity, more especially because incapacity to no longer fund or to pay can be caused by various reasons, which you've seen through the AG reports of how dysfunctional the NTOH is, right? With mismanagement of funds, corruption, fraud, irregular expenditure, and the list goes on, right? This clause then provides immunity for the state and for the minister, since the NHI is his, right? And not for the people and the existence of a financial threat for the private sector that you'll be outsourcing from, because the private sector prioritizes profit. It does not prioritize, at the center of it is not that people must get healthcare, it's that they must pay and then they must get healthcare in return, right? And that will contribute even how service delivery is done in private health facilities if the government can no longer pay, right? And this essentially means that in the event that the NHI funds run out, persons will be taken out from private facilities into public hospitals and clinics, as is the case when medical aids funds run out in the current modus operandi, right? This is a concern because the NHI has no intention of bettering public infrastructure, of increasing public capacity and facilities, of increasing the workforce of the public sector, of bettering the current infrastructural needs. Right? So now when the fund runs out, people will be chucked out from private hospitals, taken back into the public sector that is not even ready for them and was outsourcing from the private sector because they were not able to cater for everybody else's health needs. And what will be the return time of deciding the level of, I'm speaking in relation to 35.4a, what will be the return time of deciding the level of emergency in the case the fund has run out? We need to know what the waiting period is, and it must be clearly deciphered, as this poses a threat of permanent and elongated waiting periods, because anything that's run by the state is very dysfunctional, right? So now you're saying that the fund will respond based on how the emergency is, but we don't know how long that period could be. And healthcare is a very sensitive thing. If someone is in emergency now, they must be catered for now. And this may be very, it may end up in fatal cases, because private institutions will withhold their services on account that the fund can no longer carry the financial cost or has been kept in relation to the private sector, right? And awaiting the response from the NHI or this particular thing to respond if the thing is an emergency enough for them to cater for, and that will carry the cost. And in the event that the fund then comes back and says, we cannot carry the cost, it's not an emergency enough, because we don't even have the levels of how emergency is emergency for the fund to cover the cost, right? Now, let's say the fund comes back and says, we can't cater for this particular thing. We don't think it's an emergency enough. But the private sector or the private hospital has already delivered on the health service. Who then carries the cost in that instance? When the money has been kept, whether it's in ambulance services and stuff like that, because I see in 35.4a also, there's a system of reimbursing private emergency services, and it states that it is on a capped basis and stuff like that, right? In the instance that the cap has lapsed and stuff like that, firstly, who deciphers severity, and what then takes over when the private sector can no longer provide EMS services and can no longer provide health services and stuff like that. And I mean, we can't divert back to the public sector because you're no longer catering or increasing capacity in the public sector in that instance. So the capacity remains as is. The NHI doesn't make space to say we'll make EMS services better, we'll increase clinics and hospitals, we'll increase the doctors, we'll increase workforce. And the public sector will remain stagnant because the state is depending on outsourcing healthcare from the private sector. And we know you will run out of money because the amount of money spent in the private sector currently is the same amount of money spent in the public sector, despite the fact that the private sector caters for 10 to 15% of the population. Right? So these questions regarding finance, which we overlook a lot, are actually very important, especially because such clauses exist that cap services, that make, deliberations on the effect that if money runs out, then you must prove that it's an emergency, or we must first account and say, yes, it's an emergency, knowing the systemic failures of the government. And we don't know how this particular process will work. Like, will it be a cell phone thing to say, hi, I'm in a car accident. Can I quickly go to Netcare? It's just here. Like, and, you know, we hear that there's this particular clause caters for the fact that there's an institution or a system that's going to be responsible for that. But these questions are not answered. And these are fundamental questions to know if this thing will work. When the government runs out of money, what will happen? Are you taking people back to public hospitals, or because there's a claim that there's a one-tier system, but private hospitals won't treat your people if you're not paying them anymore. And that's a concern. Thank you.
Honorable Sengwa.
Thank you, Chairperson. I actually had a lot to address on this, but I'm going to try and keep it short.
Chairperson.
Yes, continue, Honorable Sengwa.
Thank you. Somebody is each and every time mute us here. Chairperson, in clause 35, perception of health services. When one look at it, the outset could submit its concern that the proposed fund has the purchase health care services for the entire nation, and that the public has very little proof of the fund's ability actually achieve this mammoth task. On a more technical note, his provision again directly limits provinces' constitutional ability to finance, plan, and provide health care services. In terms of Schedule 4, again, one could submit that it does not agree with the proposal as in and is concerned that the NHI model in its current format seriously infringes on provinces' ability to provide health care service. Furthermore, as pointed out by the stakeholders, the bill is silent on how this proposal district health management offices that are obliged to establish contracting units will account to the community. The current clause cannot be accepted in its current format. I thank you.
Honorable Wilson.
Thank you, Chair. And I must admit that I find this purchasing of healthcare services, this particular clause, very, very confusing, because I think it's a bit contradictory. And I think my concern is that we've talked about a single purchaser, single buyer, single payer. And I think that was on what the bulk of this NHI bill is premised. And yet if you read this clause, all of a sudden we're transferring monies to here, there, and everywhere. We're sending monies to provincial, regional, specialized district hospitals based on a global budget or diagnosis related groups. It starts by saying the fund must actively and strategically purchase healthcare services on behalf of users in accordance with need. Well, who defines those needs? And that is not stipulated in that. Somebody's got to define these needs. And at this stage, we're not getting to a point where we can get to where anybody or who is actually going to define these needs? It's so open, it is so broad, it is so unspecific. The moment you start dealing with unspecifics, the horse will bolt and you are going to end up closing the doors, the barn doors, long after it is gone. Single purchaser, single payer, and all of a sudden we've got transfers of funds going to a dozen optional people in here. Absolutely no time frame, no specifications for what funds will be transferred for what, why, and when, no time frames. And I think my biggest concern is, and I'm going to refer to the, and it's a comment by the Competition Commission, particularly on the health market inquiry, where in actual fact, the health market inquiry states that the opposite should be actually happening. Okay, it says that based on our findings, we recommend a set of interrelated interventions designed to promote systematic change, to improve the context within which facilities, funders, and practitioners operate, and create a shift towards a pro-competitive environment. Nothing about this. When you've got a single purchaser, single payer, now you are controlling the competitiveness, you are controlling the economic factors within the health system. I find this hugely problematic. There's no specifics here whatsoever to help us deal with this. And lastly, on the emergency medical services provided by accredited and contracted public and private healthcare service providers. In most provinces in Limpopo, public ambulances in the public health sector, well, in my province alone, one ambulance, when and if it is functional and equipped, has to cover an area of 25,000 kilometers. That's one ambulance. That's one ambulance. It is common knowledge, and it was proven, and there was an article in the newspaper last week about it, and I have access to that information. I am on the National EMS Group of South Africa, so I get this information on a regular basis. That private ambulance facilities are getting to a scene up to 15 to 20 times faster than public ambulances can. That is because there is not enough. Number two, they're never functional. Number three, they're never equipped. So there is just so much that is problematic around this. And again, I go back to what comes before, the chicken or the egg? Do we get the ambulances and get them properly equipped and then say that this clause may now become applicable, or do we make the clause become applicable before we've even got the services in which to render emergency medical care? Thank you, Chair.
Honorable Ishmael, have you raised your hand again?
Yes, Chair, if I may, I don't know if everybody has spoken, but if you could give me a second chance, I just need some clarity on something.
1 minute, Honorable Ishmael. Thank you. Yes, Honorable Ishmael, continue.
Okay, thank you. I was just waiting for you to go ahead, Chair. Okay, so looking at, or rather reading 35(4)A and 35(4)B, I don't know, English is a very ambiguous language. So I think it depends on where you're sitting and reading this thing. I mean, from the point of view. When I'm reading clause 35(4)B, I'm reading it as it's actually a conflict with 35(4)A. 35(4)A states emergency medical services provided by accredited and contracted public and private healthcare service providers must be reimbursed on a capped-based fee basis with adjustments made for case severity when necessary. Then 4B reads, public ambulance services must be reimbursed through the provincial equitable allocation. Now, I don't know, it somehow, it doesn't, it's like in conflict of each other. unless the department can give us some clarity on this going forward. And again, I think I missed this when I was having my input, you know, 35, clause 35, 4A. I don't know if it was mentioned before by honorable members that spoke before me, or rather after me. Definition for capped base fee. Again, I'm going to specify again, I seem to be saying it all the time with each and every clause. There are no specifications of what is actually being referred to here. We need to know, you know, everything must be specified what this will actually comprise of. Thank you, Chair.
Thank you very much. Honorable members, from myself, I want to talk on clause 35.2. Just to state that the ANC supports this clause, which requires that funds be transferred directly to accredited and contracted service providers based on a global budget or diagnosis-related groups. And the reason we support it is because the measures are meant to increase the efficiency, sustainability, and quality of health service provided. Currently, funds are given to providers without a means, or to healthcare practitioners without a means to assess whether primary health care and hospital services providers offer quality health services. The intention of the NHI is to address this issue in terms of the provision of quality healthcare and also the assessment of the provision of quality healthcare or not. Then, as a strategic purchaser, the fund must establish a purchaser-provider split that enables it to proactively determine and purchase healthcare services directly from providers. These providers will include public and private providers at different levels of care. At inpatient or hospital levels, alternative reimbursement strategies that have been shown to yield best value for money must be deployed, including the diagnosis-related groups. Information systems must be used to monitor, evaluate, and plan for service use under alternative reimbursement strategies. This will assist the fund in identifying gaps and developing interventions to address cost escalation. I want to support the input that was given by Honorables Munyai, Siwela, and Kaba and Harvard, including the amendments which were recommended on clauses 35.3 and on clause 35.4a, which addresses the point which was raised by Honorable Ismail in terms of the public private emergency medical services. Thank you, honorable members. Honorable Wilson, you've raised your hand again.
Thank you, Chairperson, and I actually have a confession to make. Not big enough to say when I didn't make a mistake. I misinterpreted clause 2 of 35. So, but having said that, I was reading it as that funds would go to the provinces, not in where it actually categorically states the service providers who are accredited and registered. But having said that, Chair, I mean, we know, and so the fund must transfer funds directly to accredited and contracted central, provincial, regional, specialized and district hospitals based on a global budget or diagnosis related groups. My other point still remains. There's no time frames, number one, and there's no indication of what we classify as a need. But I think my biggest concern is that the Office of Health Standards Compliance has showed categorically, and they've presented before this portfolio committee, that very few, and in some areas none, of the hospitals, including those that are specialized here, can be accredited. They just simply do not meet the standards. And until such time as that has happened, this clause it means nothing, because if you don't have accredited service providers, there's no point in you paying them for anything. Thank you.
Thank you very much. Honorable members, that takes us to clause 36, role of District Health Management Office. A District Health Management Office established as a national government component in terms of Section 31A of the National Health Act must manage, facilitate, support, and coordinate the provision of primary healthcare services for personal healthcare services and non-personal health services at district level in compliance with national policy guidelines and relevant law. Honorable Munyai. Let me just wait to see if there are any other hands. Honorable Munyai, Honorable Wilson, Honorable Kaba, Honorable Ismail, Honorable Clark. Another clause, clause 36. Honorable Chirwa, Honorable Tembakwayo, Honorable Siwela. I just need to still write this down in the right order since I'm just raising, and then Honorable Abbott. Just give me a moment. We started with Munyai. Then Wilson. Am I right? Munyai, then Wilson. Was it Clark? Wilson. Ismail was next. Kaba was next. And then it was Dr. Tembakwayo. Tembakwayo, Chirwa, Siwela, Abbott. Thank you. In that order, I'm going to repeat it. Munyai, Wilson, Ismail, Kaba, Tembakwayo, Chirwa, Siwela, Harvard. Honorable members, if you can just continue in that order.
Thank you very much, Honorable Chairperson. The African National Congress rise to support clause 36 based on the following reason, Honorable Chair. The District Management Office must be established as part of the Department of Health for the purposes of planning for the service that will be provided at a district level. The District Health Management Office will manage, facilitate, support, and coordinate the provision of the personal health care, and non-personal health care services at the district level, such that to comply with the national policy guideline, priorities, and relevant laws, they will perform functions that are crucial for running primary health care services. I think it's important to note that point, including services provided by accredited providers in the public and private sectors. The DHMOs must coordinate how the personal and non-personal services are planned for within a district in compliance with the National Health Act of 2003 and as part of decentralized planning and decision-making process. This must be effected through the consequential amendments as envisaged in Section 31 of the National Health Act. The DHMO must report to the department as part of the integrated planning for the entire health sector, and therefore they need to establish a government component for this purpose. Honorable Chair, that will be my submission, because some critics, Honorable Chair, may seek to think that they would want to undermine the unitary government by thinking that there's need to be federalism that needs much more control at a provincial level. So therefore, this is my submission that clarifies the principal purpose of the DHMOs. Thank you.
Thank you, Chairperson. I'm going back to our last meeting with regards to this, and I'll requote my concerns again there because it is relevant to this section. Correct me, Chair, we're 36, hey? Section 36, yes, okay, so I'm in the right place. Okay, the establishment of district health management officers through amendments to the National Health Act, and I have that in front of me. These are established as national government components. These structures effectively strip away the powers of provinces to finance, plan, and district health services. They are stripped of this, and it now gets allocated to the Minister of Health. The provinces are stripped from this. Amendments to the National Health Act further stipulate that DHMOs must establish contracting units which will receive funds determined by a formula from the NHIF to contract with primary health care providers. These contracting units will be established as part of a DHMO and will be required to contract with the NHIF to receive funds from the NHIF. And I said this before. A government component, which is what this district health management office is going to become, can only be established if the prescribed feasibility study is conducted and its findings recommended the establishment of such a component. No feasibility has been done. Without a feasibility study and a recommendation of the establishment of such a component, this Section 36 becomes totally null and void. We cannot find any evidence of a feasibility study being done on this. So that is my concern about the whole thing. But one of the other things that concerns me, and I'm going back to the Health Act, is the establishment and composition of provincial health councils. Now that is part of the Health Act. We're dealing with provincial officers here and in specific district officers. Can somebody please explain to me where the Health Act states that we have to have provincial health councils, how they are established, who should be on them? That includes councillors, specialists, all sorts of things, members of executives, and what the functions of that provincial health council are. And my concern is we are going to have a big clash here. Do we now take this whole section out of the act and pretend that there's no such thing as establishments of provincial health councils anymore? Or where do we now start including them? How do they fit into this role of district health management officers? We've got a clash of acts and wills here, and the constitutionality therefore becomes very, very imperative. I don't think it will stand. Thank you.
Honorable Kaba, no. Honorable Ismail.
Thank you, Chair. I was having a problem unmuting myself. Sorry for the delay. Okay, so I'm just very much concerned with this clause. There are basically three issues that I would like to highlight. One is that just for the purpose of this bill, I'm just concerned, and I'm highlighting, that district health management officers' capacity to actually oversee mental health care within, the primary care scenarios. Now, I'm just worried that they're not efficiently capacitated, especially considering the primary care system's central role in referrals. So I'm worried about that. But more importantly, if I can put it that way, if you're looking at the National Health Act, the DHMO is established as a national government component. This is to support and coordinate the provision of primary healthcare services at a district level. Now, this should not be a centralized office, but one of a provincial complement at the very least. Now, these structures here, as I'm reading it, will effectively strip away the powers of provinces to finance, plan and district health services and allocate them to the Minister of Health. I need some guidance on this from the legal, from the legal advisors going forward. Now, also, this framework is established that makes the proposed DHMOs accountable to the communities they will purchase services for. Now, there's no clarification of what kind of public structure a so-called contracting unit is, given that, they would have substantial delegated powers to procure health services. And this is now really concerning and worrisome. So we need more specifications. We need a legal advice on whether this is, again, unconstitutional going forward. Thank you, Chair.
What about Kaba?
Thanks, Chair. Chair, I think I rise in support of what Honorable Mnyai had clearly outlined. I think that is quite specific with regard to clause 36. But once more, Chair, to indicate that the national government components are intended to provide greater management autonomy, but working to national to ensure cohesion across boundaries for continuity of service. And Chair, the Constitution says that the health is a concurrent function, and the decision to allocate responsibility was taken when the Health Act was passed. It is not unconstitutional. So I think it has to be understood. And like as earlier said, Chair, for other honorable members to raise questions, we'll continue to provide clarity. Thanks, Chair.
Honorable Temba Koyo.
Thank you, Chairperson. The Sixth Parliament, Shapers and Shakers, the economic freedom fighters led by the President and Commander-in-Chief Julius Sello Malema, represented by myself and the Honorable Naledi Chirwa, is not supporting the clause 36. The Auditor General has mentioned continuously every year the inability and lack of competencies by the NDOH to run and oversee the mental health care. The constraints faced by the district health management team as they thrive to ensure the delivery of quality public health care in a rapidly changing environment is characterized by, amongst others, the following challenges. The problems of issues such as inadequate delegation of authority to district health management teams. Problems like defective budgeting processes that are the order of the day of the National Department of Health. Problems involving the staffing issues, which are forever ongoing. The problems of the lack of managerial skills and vacancies in key managerial positions, and we are all aware of such continuing problems. The problems of an ineffective use or absence of quality management information system to support decision making. This is an area of strategic importance and has to be attended to with caution. Consultation process between private sector and relevant stakeholders must take place. A need for the appointment of suitable qualified management teams should play a critical role here. So an urgent deliberation on this issue need to take place. And I still repeat, we don't need the advice and the intervention nor the reply of any of the honorable members that belongs to ANC. Thank you.
Honorable Chirwa.
Thank you very much. Chairperson, I think the minister must come here and really deliberate more and tell us on a concise and a distinct plan of action, right? In ensuring primary health care become the true manifestation and not just something that's written as a by the way issue in this particular bill, noting infrastructural inadequacies, medicinal shortages, lack of healthcare staff and workforce in public sector. What will then be the systemic method of firstly resolving these barriers to primary health care? When the NHI overtly states no intention of bettering the public healthcare system with the interest of primary healthcare prevention and education. And I'm adding prevention and education because they are part and parcel of the mandate and obligation of the NDOH and are married to primary healthcare. You can't separate the three. Despite the fact that the ANC government is satisfied with a curative system and not a preventative one, right? We really do need an in-depth and researched document, if I may, and presentation on the possibility of this being a reality. This is a requirement, right? And the district-based system, to be honest, is very essential in any large project, right? We even made this recommendation to the former ministers, William Kize, in the early days of the COVID pandemic, which he sadly only took up way late and with minimal investment in the accuracy and valid information. Our recommendation was that he should devise district-based information systems that receives COVID information in real time, right? And capacity in SA is questionable on district-based systems. And the COVID pandemic highlighted this because despite the fact that he took up our recommendation, it wasn't implemented in the way it was. And the width of government will was very much highlighted in investing in this particular aspect of district-based systems, right? Minor issues like verification of information had no way of being proven. We were just told that today 300 people died. And there was no way to prove it. There was no system, there was no bucket of evidence that we could refer to, even as legislators, even as people who do oversight, despite the fact that district-based operational systems were now in existence. Even they couldn't verify from their information, from the hospitals that they were receiving this information from. So I'm raising this particular concern on the kind of manner district-based systems have been presented under the ANC government. They are dysfunctional. They cannot be, we do not get accurate information. We cannot verify information. We just receive it on Twitter and everything must just go by. Fine, the general public can, because information is also important to be distributed to persons, right? But if there is no verification system in a district-based system or a monitoring system that can be easily accessible, especially to public representatives, then it is futile because it means people are sucking information from their thumbs. And that's not the kind of district-based system we envision, especially for a large project such as this one. So that's why I'm saying that we need the minister to come and tell us and deliberate concisely and distinctly what does this district-based system look like, and break down each and every aspect of that particular thing, because I am sure it has not even been thought out on that level to begin with. And the minister must also explain this clause and the kind of intervention that they envision to see this being a reality on a technical and a scientific and a managerial level, and how it will result in the guarantee of accessible and quality primary healthcare, prevention and education, as is the obligation and mandate of the NDOH, that in actual fact has never been realized since 1994. So for as long as I've been alive, the realization of primary healthcare prevention and education has not been a tangible reality for each and every person living in this country. Thank you, Chairperson.
Honorable Siwela.
Thank you, Chairperson. I rise to support Comrade Munyai and Honorable Kabe on his submission. You see, Chair, the ANC is cognizant of the fact that the district offices currently do not operate efficiently and are disempowered to implement their mandates as structures that are to be responsive to the needs of communities at the district level. They have not served the purpose of what they are intended for. So there is a need to improve their accountability, which is quite important. Also, Chair, when we talk about the national taking responsibility of a province, it is clearly articulated in Section 100 in the Constitution. The national is given the authority to intervene to ensure fulfillment of that constitutional obligation to give healthcare. Since you said the health system is run by the provinces and districts, okay, sorry, it's not good enough. Then national is correcting through NHI. National takes the services and redelegates when necessary. Thank you, Chair.
Thank you, Honorable Harvard.
Thank you, Honorable Chair.
Hold on, please. Honorable Siwela, please, and Honorable Wilson, please switch off your mic.
So sorry, Chair.
Yes, thank you, Honorable Chair. I just here rise to support all submission made by Honorable Mayai and also support the contribution made by Honorable Kaba and Honorable Siwela. Thank you.
Thank you very much, honorable members, for all of your input. From myself, I had spoken about the Alma Ata Declaration before, and also about the Astana declarations, which places primary health care. I forgot you, honorable, your hand is not on my list, but I'll give you an all right, let me give you first, and then I will end off. Honorable Clark.
Thank you, Chair. Remember, I know when my hand was up, my hand was up. Just in terms of this clause, a DHMO is established as a national government component to support and coordinate the provisions of primary healthcare services at a district level. This should not be a centralized office, but one of a provincial compliant at the very least. These structures effectively strip away the powers of provinces to finance, plan, and district health services and allocate them to the Minister of Health. And Member Wilson has also spoken about this point. The DHMO will be a government component. This can only be established if the prescribed feasibility study is conducted, and its findings recommended the establishment of such a component. And if you look at the Minister of Public Administration, 2007, section 10(7)(a) and 1, no evidence of such feasible study could be found. However, apart from the appraisal of the 11 NHI pilots, which did not test health authorities' designs or the implications of wide delegations allocated to public entities, no framework is established that makes the proposed DHMOs accountable to the communities that they will be purchasing services for. There's also no clarification of what kind of public structure so-called contracting unit is, given that they would have substantial delegated powers to procure health services, is very concerning. Thank you, Chair.
Thank you very much, honorable members. I was speaking about the Alma Ata Declaration and the Astana declarations, which placed primary health care approach at the center to ensure that anyone is not left behind. Now, what this clause speaks to is about the strengthening of the district as a platform to coordinate the provision of services at the primary healthcare level. Therefore, it's imperative that strong, empowered district health management officers are implemented. The ANC supports the establishment of these DHMOs to ensure that personal and non-personal health services are planned for, coordinated, monitored, so that there is information for proper planning. The national government components should ensure and will ensure that the national sphere has proper oversight over this level of care. So I support it, which has been put forward by Honorable Munyai, Honorable Howard, Siwela, and Kaba. And so, honorable members, I am trying to consider the time having come to the end of this clause. We had indicated that we will have this meeting until 1300 hours today. I was mindful of the of when plenary is sitting, and we were informed that it's sitting at 1300 hours. When I look at clause 37, it's a quite lengthy clause, and I do not think that we'd be able to complete it before 1330, even if we were to extend to 1330. So therefore, in consideration of that, unless there is a view that we continue to 1330. It's plenary sits at 1500. Oh, I made a mistake. I said 13. I meant 1500. Honorable Wilson.
Thank you, Chair. If I may, obviously we work on the agendas and build our timeframes around the times that our meetings are advised. We were advised that it will be 1 o'clock. Some of us, while I understand the chair, the sitting is only at 3 o'clock this afternoon. We have made arrangements to meet with various other people after 1 o'clock. So I would support your proposal that we end at this point. I do not want us to go into a clause and then not have it finished, because at the very next sitting, we're going to start at the beginning of that clause all over again. Thank you, Chair.
Honorable Munyai.
I know that the sitting is at 3 o'clock, but I thought perhaps it's the setup of the meeting that the chair would want us to conclude at this time. But I'll suggest that at least if it's feasible, that we do 37 and 38, and perhaps to really 40. That would be very helpful on our part, Honorable Chair.
Thank you, Honorable Munyai. Honorable Tembakwayo, and then Honorable Clark. And Van Staden.
Is it me, Chair?
Yes, it's you, Honorable Dr. Tembakwayo.
According to the invite that is on our WhatsApp group, it clearly states it's an invitation of the Portfolio Committee on Health meeting scheduled for today, 31st August, from 9:30 to 13 hours. Let us respect this decision that was taken. We are not going over the time that is specified per invitation. Thank you.
Thank you. Who was next? Honorable Clark, and then Honorable Van Staden.
Sorry, Chair, I've got another commitment. I've got another meeting now. I didn't know we were going to extend the time. Thank you.
Honorable Van Staden.
Same chairperson. I have the same problem. The invitation was till 1 o'clock, so I've planned other arrangements after 1.
All right, honorable members, we.
Chairperson, I want to withdraw my proposal.
Yes.
Because let's stick to the invitation.
Yes.
Yeah. Chair.
I must say, Honorable Chair, let's
No,
stick to the
Chair,
program. Can I finish, please?
Honorable Kaba, I will Honorable, no, Honorable Kaba, you're transgressing my rules.
Honorable Chair, I'm saying let's stick to the program precisely because the invitation, even to the non-participating member, would have been at 1 o'clock. So therefore, let's stick to that. And I accept that that is the official invitation that came from you. And let's stick to that. And I withdraw the initial proposal. Thank you.
Yes, thank you, Honorable Kaba. Now that you should raise your hand, we will see it on the platform and we will give an opportunity to speak. And you did, but we were late to recognize your hand. But you may speak now.
No, Chair, I think Honorable Mnyai had guided the meeting and I support him. Thank you, Chair.
Thank you very much. Honorable members, that comes to the end of our meeting. The meeting is adjourned. Thank you.